Some introductory remarks regarding these guidelines, and at the outset I should indicate that I have no COI or RWI relevant to the guideline. First point I want to make is that the guideline structure, that the committee members come from a variety of disciplines. They're not just cardiologists, they're lipidologists, internists, nurses, we even have a patient representative. So they include the initiating and organizing partners, American College of Cardiology, American Heart Association. These guidelines have been reviewed and endorsed by the Cardiovascular Pulmonary Rehabilitation Association, Academy of Physician Assistants. Guidelines was supported by systematic review that was chaired by Peter Wilson, and you can see the other members in that group here. They were charged at looking at the evidence regarding outcomes and new medical therapies. The conclusion was that in their systematic review of the evidence for adding non-statin lipid monitoring therapies to statins, which is really what we're going to talk about here in addition to some other new findings, we found evidence for ezetimibe and PCSK9, but none for niacin or cholesterol ester transfer protein inhibitors.
All other members of the panel, Dr. Grundy, had no relevant relationships with industry or conflicts of interest. So if we could have the video, please.
It has been a great honor to lead an outstanding writing committee, as well as a superb American College of Cardiology, American Heart Association team. My special thanks goes to Dr. Neil Stone, our Vice Chair. Dr. Stone's contributions to the guidelines have been enormous. I'm sorry that mobility problems prevent me from being here in person today. This first slide is some of the main features of 2018 cholesterol guidelines. They are evidence-based clinical guidelines built on the foundation of a healthy lifestyle. LDL cholesterol is the dominant lipid risk factor. RCTs of LDL-lowering drugs receive priority in the guidelines. Newer LDL-lowering drugs are promising as adjuncts to statin therapy. And we provide you a key point, the top 10 messages that lead off the guidelines. I will summarize these top 10 points. First, we emphasize healthy lifestyle across the lifespan. They are the foundation of the guidelines. The features of a heart-healthy lifestyle include an anti-atherogenic diet, weight control, regular physical activity, and avoidance of tobacco use. Moreover, a heart-healthy lifestyle reduces risk for ASCVD at all ages. It reduces development of risk factors in younger individuals, and it is the primary intervention for metabolic syndrome. Second, in patients with clinical ASCVD, the recommendation is to reduce LDL cholesterol with high-intensity statins or maximally tolerated statins. The goal is an LDL cholesterol reduction of 50% or more. Third, in patients at very high risk for ASCVD, we recommend using the LDL cholesterol threshold of 70 milligram per DL to consider adding non-statins to statin therapy. Non-statins include ezetimibe and PCSK9 inhibitors. Very high risk is defined as a history of multiple major ASCVD events or one major ASCVD event plus multiple high-risk conditions. In patients at very high risk for ASCVD, when the LDL cholesterol is greater than 70 on maximally tolerated statin therapy, first add ezetimibe. Then, if LDL cholesterol remains over 70, a PCSK9 inhibitor is reasonable. Considered at mid-2018 prices, cost effectiveness is low, but it improves as cost comes down. Fourth, in patients with severe primary hypercholesterolemia, that is LDL greater than 190, the recommendation is to begin high-intensity statins. It's not necessary to calculate 10-year risk. If LDL remains greater than 100 on maximally tolerated statins, then adding ezetimibe is reasonable. If LDL cholesterol is on statins plus ezetimibe still remains greater than 100, and if the patient has multiple risk factors, adding a PCSK9 inhibitor can be considered. The economic value, however, is uncertain at mid-2018 prices. Number 5, in patients with diabetes, those 40 to 75 years who have an LDL greater than 70, the recommendation is to begin a moderate intensity statin. There's no need to calculate 10-year risk initially. If the patient has higher risk due to multiple risk factors or is 50 to 75 years old, then a high-intensity statin is reasonable to achieve a goal reduction in LDL cholesterol of greater than 50%. What is the first step in making a decision about statin therapy in primary prevention in adults 40 to 75 years? The first step is risk assessment using a risk calculator to estimate 10-year risk for ASCVD. 4 categories are identified. First, low risk, less than 5% 10-year risk. Borderline risk, 5 to up to 7.5%. Intermediate risk, 7.5 up to 20%. And high, greater than 20%. In primary prevention, it is important to have a clinician-patient risk discussion before starting a statin. Key topics to discuss are all the major risk factors in the 10-year risk, benefits of lifestyle and statin therapies, potential side effects and drug-drug interactions, cost of therapies, risk-enhancing factors that favor statin therapy, the potential utility of coronary artery calcium measurement, and patient preferences for shared decision-making. 7, in adults 40 to 75 years and 10-year risk greater than 7.5%, and those in intermediate risk up to 20%. If risk discussion favors statin therapy, start a moderate intensity statin. Aim to reduce LDL cholesterol levels by 30% or more. In high-risk patients, that is 10-year risk greater than 20%, aim to reduce LDL cholesterol by 50% or more. And in this case, high-intensity statin is favored. In adults 40 to 70 years with intermediate risk, 2 important points are made. First, evaluate risk-enhancing factors that favor statin therapy. And second, if risk status is still uncertain, consider using coronary artery calcium, which will help to define risk status. Number 8, here are some of the key risk-enhancing factors in intermediate risk that favor statin therapy. Family history. Number 9, in intermediate risk patients, if a decision about statin therapy is uncertain, consider measuring coronary artery calcium. If coronary calcium is 0, statin therapy may be withheld or delayed, except in cigarette smokers and those with diabetes or those with a strong family history of premature ASCVD. In intermediate risk patients with a positive coronary artery calcium score, that is the presence of coronary artery calcium on the scan, a CAC score of 1 to 99 favors statin therapy, particularly in those who are over 55 years. A CAC score of greater than 100 or the 75th percentile warrants statin therapy in most patients unless this is deferred in the risk discussion. Finally, 10, assess adherence and calculate percentage response in LDL cholesterol to lifestyle and medication. First, repeat lipid measurements 4 to 12 weeks after starting statins or adjusting the dose. Thereafter, repeat measurements every 3 to 12 months as needed, and calculate the response in terms of aim of therapy as percent reduction in LDL cholesterol compared to baseline. And finally, remember that in very high-risk patients, an LDL cholesterol greater than 70 warrants consideration of adding non-statins. I would like to thank you for your attention